This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews. Welcome to episode 74 of Blood and Cancer. I am Nick Andrews, and I'm joined this week, as I always am, by Dr. David Henry, the editor-in-chief of MDH Hematology Oncology, and the host of this podcast. And Dr. Henry, all of a sudden, out of nowhere, summer just sort of happened to us.
Well, it sort of did. Actually, before coming on, of course, your children, whether they're 2 years old or 22 or 42, they're never off. And so I got a call from my daughter in her new home. The air conditioner's not working. And it's 90 plus in the evening here in Philadelphia.
No.
So that'll be my job after we finish tonight.
Here's the million-dollar question. Would you rather be incredibly hot or incredibly cold?
Oh, incredibly hot.
No question.
No problem.
I think I'm trending in that direction. I used to say cold because you can always add more layers and you can only take so many layers off. But with every year of age, I find myself, man, the cold is just the worst. I just hate it so much.
Give me the heat. No,
100%.
No problem.
Speaking of heat, every year summer rolls around. It's time for ASCO, and we discussed what virtual ASCO was like for you. You were tickled by it, and you thought it's something that might stick around. And that's relevant here because this episode we have a recurring guest, and we're going to talk about 2020 ASCO.
So that was really fun. Our annual now of two, we hope to keep it going annually. Dr. Lyss and I, who's a wonderful friend for many years and colleague who's in St. Louis at Washington University. We do a post-ASCO, what we thought was pretty hot and worth talking about. We did each 5.5, meaning 5 really hot things, and maybe the half was something that was important to know, but it was a negative trial. So those are important to know as well. And so we gave a lot of detail and just the abstracts, and the show notes will have a lot of detail in there as well on our mdh.com/hematology-oncology website.
Yeah, absolutely. And I think that meetings are always so interesting because there's so much going on. There's so much to digest that you can really kind of regurgitate and think about it for a long time afterward. And of course, at MD Edge, we'll be publishing stories and things that happen from the virtual meeting for a long, long time. But the research is impactful 24/7 if you're a clinician. So I think this kind of thing, when there's a flood of abstracts and talks and different educational sessions, and in a typical year, a lot of it can be lost, but that's what we're trying to wade through that and figure out what's the most relevant. And you and Dr. Lyss have always done a great job of that, and we continue that today.
And the virtual meeting, I think if anything, we were so focused on, boy, this is going to be different. What's it going to be like? And the presentations were crisp. They were pre-recorded so that they could be loaded and happen. And with chat going down the right-hand side of your screen that you could chat in on, and the presenters would then watch those chats and answer as appropriate. Yeah, the 5 hours that I spent each day, Saturday and Sunday, watching just kind of flew by. So it was really interesting format.
Yeah. Do you think that you were more entertained by ASCO than you might have been by the NCAA tournament or March Madness?
I love the NCAA March Madness. I really do. So I really miss it. And as we speak, the NBA might actually get it together to play in Orlando, I think, at Disney property, so we'll all be so hungry for sports.
Literally,
we'll all become basketball fans.
Basketball, hockey is supposed to start up in a bubble scenario as well. It seems like we're turning a corner on COVID. Maybe not. Some states reopening. I know apparently Michigan had their worst day of the pandemic, and all of that information. That's stuff that we cover at MDH, not necessarily at the Hematology Oncology page, but if you're interested in following that, Medscape and MDH, of course, cover that in its entirety. Dr. Eric Topol, the editor-in-chief of Medscape, a lot of COVID information as things start to open back up. And hopefully we'll only be talking about basketball and the NFL this summer and this fall. That's what I want to focus on. Not that there's a bunch of other stuff going on in the country, but sort of hoping for some positivity myself.
Exactly. And, to highlight, as we just did, what you're about to hear about ASCO, but always to tease everyone on next week's show, Dr. David Mincer, who's a really talented generalist. It's hard to call him that. He seems to know a lot about everything. He's like a general specialist. He does a review from time to time, and he just did one on a journal club format of new FDA approvals, of which there are so many in our world of hematology oncology. So please listen to that next week, and there'll be show notes of what he said, listing the drug, the indication, the side effect, the dose, and where you might use it. So that's coming up in next week's show.
Of course, and that is episode 75. If you're scrolling through your feed and listening to these back episodes, that episode is episode number 75. And of course, you can find a bunch of back episodes wherever you subscribe to podcasts. Dr. Henry, thank you so much for hanging out with me. I hope you stay cool, as these 90-degree days apparently don't look like they're going anywhere in Philadelphia.
And same for you. We'll stay cool. Everybody stay cool. See you next week. I'm Dr. David Henry, your host, and you are listening to the podcast Blood and Cancer. And I'm really delighted to be doing an ASCO review this week and talking to my long-term friend and colleague and together trainee way back when, Dr. Alan Lyss, who is a medical oncologist, also associate professor of medicine at Washington University, where he's also a sub-principal investigator at the Heartland Cancer Research and Corporation. Alan, welcome to the podcast.
Thanks very much, Dave. It's a pleasure to be speaking with you.
Boy, it certainly is likewise. And since we're going to review ASCO, why don't you give just a summary of what you thought it was like to go to ASCO in your home office, and I'll do the same. So how was it last weekend?
I thought it was terrific, to be honest with you. After some initial technical hiccups, I really think ASCO needs to be commended for organizing and implementing, such a terrific meeting for so many people. I'd be a little surprised if this wasn't the largest virtual meeting attempted during the pandemic. And I don't know about you, but I did not feel at all cheated about the quality or quantity of what I walked away from this virtual meeting. There was a lot of information expressed and conveyed. And the thing that really stunned me the most was that I think ASCO met with flying colors the challenge of infusing the warmth and the spirit of a shared mission that I always get when I attend the ASCO meeting. I thought Skip Burris's presidential address was really terrific, and Dr. David Feigenbaum, the special lecturer, definitely infused a feeling of warmth and personal mission that I thought was just terrific to kick the meeting off.
Well, I all I can do is say ditto. I couldn't agree more. I thought the meeting went very well. I had a few little glitches in the beginning. It said unstable, and then it stopped being unstable, and it worked with so many thousands of people watching. Of course, they're all archived. If anyone hasn't seen something they want to see, they can go back and look at it again, or for the first time like I've done since then. Skip Burris's address was phenomenally good, as was Feigenbaum, our presidential special speaker. And then the presentations went off bang, bang, bang with questions happening down the side. You could watch comments. Really was very, before I knew it, 4 or 5 hours gone. I did both Saturday and Sunday, and it went very well. So we'll see, presumably we'll be in Chicago next year, and what will they keep from this year, we'll have to see.
Absolutely. I think all of us missed the opportunity to exchange thoughts with colleagues and to speak informally and to hear the buzz in the hall. We all missed that. Maybe there's a way to recapture some of that virtually, or potentially attend the meeting and recapture all of that. We'll see.
I think, I'll bet you they won't completely go back to the old way. They'll be kind of a hybrid, and I think that'll be better for all of us in every way. So let's go on to our assignment today. So you and I scoured the hallways virtually of what was happening at ASCO, and each came up with I call it 5.5, because we have 5 abstracts we want to review and highlight, and then maybe the half is an honorable mention. In my case, once again, a negative study. So I'll mention that at the end. So why don't we go back and forth? Why don't you start first, and then we'll go back and forth with each of us doing 5.
Well, the first one that I wanted to bring up, Dave, that I thought was really a significant study was abstract 9500. It was the 3-year update of the Checkmate 227 study. And as you probably know, that study examined a chemo-free regimen of nivolumab plus ipilimumab versus a traditional platinum doublet as first-line treatment for advanced non-small cell lung cancer. And what they did was they treated patients with stage 4 non-small cell, any histology, any PD-L1 expression level, but no known driver mutations. And they treated them with either the novel combination of nivolumab and ipilimumab, a chemo-free regimen, or with traditional platinum doublet chemotherapy. Now, there was a third regimen to which patients were also randomized. It was either nivolumab alone for patients with high PD-L1 expression of at least 1%, or platinum doublet chemotherapy with nivolumab for patients whose PD-L1 expression was less than 1%. There was no crossover in this trial, and the primary endpoint was overall survival. But as you might guess, over 75% of the patients who did not receive a checkpoint inhibitor as part of their randomized therapy eventually received one. And what they found at first blush, I thought was an incredible win for nivolumab plus ipilimumab. For the patients with PD-L1 expression of at least 1%, the 3-year overall survival rates were 33% for nivolumab plus ipi, in comparison with 22% in the chemotherapy arm. When did you and I ever think we'd be talking about 3-year survival with 3% for metastatic non-small cell lung cancer? The nivo arm, as you might guess, was intermediate between those two. But the interesting thing was that if a patient had a CR or PR in the first 6 months of their therapy, almost 40% of the nivo plus ipi patients remained in response at 3 years, in comparison with, as you might expect, only 4% of patients in the chemotherapy arm. So 10 times more in the nivo plus ipi arm. Now, if a patient's PD-L1 expression was 0, the 3-year overall survival with nivo plus ipi also wasn't too bad. It was 34%, but it was only 15% for chemo alone. And again, it was intermediate for nivo plus chemo. And once again, if a patient had a response by 6 months, even for patients with PD-L1 expression of 0, about a third of them on nivo plus ipi were still in response at 3 years, in comparison with 0% for the chemo alone group. And what I felt this meant to us and to our patients was not as much as you might think at first blush, for 2 reasons. One was toxicity and the other was time to respond. Anybody who's given nivo plus ipi knows this is not for the faint-hearted. Grade 4 toxicities were seen in about a third of patients. About twice as many of them stopped their treatment prematurely as stopped chemotherapy for toxicity. But the other thing that the discussant brought up that I thought was really interesting is that if a patient is that for nivo plus ipi, if there was clinical deterioration and death within the first 6 months, there were more of those on nivo plus ipi than there was with chemotherapy alone. It took about 6 months for the curves to cross. And I personally felt the bottom line here is that there's still room for clinical judgment. Disease-associated symptoms, burden of disease, performance status, comorbid conditions, and perhaps even advanced tumor genomics, like having the presence of a molecular profile that might code for resistance to an immune checkpoint inhibitor. I think all those things still have to enter into the equation of whether a chemo-free regimen is appropriate for a given patient.
Yeah, and we actually interviewed Jack West a week or so ago, and this is prior to ASCO, talked about exactly that. Tailor-make to your patient, now that we have so much choice, checkpoint inhibitor plus chemo, checkpoint inhibitor only, et cetera. Well, I thought I saw that as well, thought that was really interesting and a little more in the side effect profile, but doable and considerable. Well, let me go then to my first one, Abstract 501. So I'll read the title. 3-year follow-up of neoadjuvant chemotherapy with or without anthracyclines in the presence of dual HER2 blockade for HER2-positive breast cancer, the TRAIN-2 study, a randomized phase 3 trial. The presenter was Anna van der Voort, and she's from the Netherlands. And so the authors studied here neoadjuvant therapy, trastuzumab, pertuzumab, received by all, HER2-positive disease, locally advanced, stage 2-3, and they then randomized to get one of 2 different chemotherapy arms, either 3 cycles of FEC, so the ezeparubicin anthracycline, and 6 cycles paclitaxel carbo, so 3 and 6 in the first arm with 3 of anthracycline, or 9 cycles of paclitaxel carbo only, and then that followed with a year of trastuzumab, as we typically do for HER2 positive. Radiation may have been in there if you had lumpectomy, endocrine therapy in there if you were hormone positive. So what did they find? They had a lot of patients in the international trial, 438 patients, randomized, and they found a 3-year event-free survival of 92 in the experimental arm and 93, or so I should say in the anthracycline arm and 93 in the non-anthracycline arm, event-free survival. So no difference. And the overall survival estimates, so OS, comparable 97 versus 98. So what's their point? They said, given this, and I underline this is in a HER2 population, although it's being sorted out in non-HER2 populations, a physician could choose a non-anthracycline containing regimen and avoid the acute and chronic toxicities. I think there's more nausea and vomiting. We always worry about the heart. We always worry about downstream bone marrow effects. So do we really need anthracyclines in this neoadjuvant, let alone adjuvant setting? So this was in the HER2 population. So I thought that was one more piece in the non-anthracycline story of whether or not you need them. So interesting. Back to you.
I felt the same way. And as you and I learned many years ago, you can't be afraid to unlearn something that you thought you already knew. You know, if drugs A plus B plus C are better than A plus B, and if C is such a terrific drug, it might be possible to ask whether you needed A at all.
Yeah.
And it seems like that's what they did in this study.
Agree. Yeah, interesting. So that story continues.
The next one I wanted to bring up was actually one of the plenary session talks. It was LBA 5. This was the ADORA trial, and it kind of keeps us in the theme of non-small cell lung cancer for my presentation. And this was a study of osimertinib as adjuvant treatment for patients with EGFR mutated non-small cell who had had a complete tumor resection. And what they did in this trial is they randomly assigned patients with stage 1B to 3A EGFR mutated non-small cell lung cancer who had come through potentially curative surgery to either adjuvant osimertinib at standard doses or an identical placebo for 3 years. Now, if patients required adjuvant chemotherapy, they were allowed to receive it for whatever stage they had after a discussion with their oncologist. But the osimertinib or placebo began after the conclusion of the adjuvant chemotherapy in that case. And they randomized almost 700 patients on this trial. They had co-primary endpoints of disease-free and overall survival. But the Data Safety Monitoring Board recommended stopping the trial 2 years earlier than planned because of dramatic differences in disease-free survival. And what they found was that for stage 2 to 3A patients, the disease-free survival hazard rate was, get this, 0.17 in favor of osimertinib.
Wow.
The curve separated early and progressively so that by 3 years, the disease-free survival for osimertinib was 80% in comparison with 28% for placebo.
And tell me again, these are mutated driver mutations or not?
EGFR mutated driver mutations.
Got it, okay.
Right. For stage 1B patients, the disease-free hazard ratio was 0.50, so not nearly as impressive, but, 0.50 is a hazard rate that in any other context would be viewed as a huge win. So at 2 years for the stage 1B patients, 87% of those on osimertinib were alive, free of disease. Alive, free of disease, compared to 70% for the placebo patients. Now, for any adjuvant treatment, obviously toxicity is a huge issue, but it wasn't much of a serious issue with osimertinib. The patients stayed on osimertinib actually longer than they stayed on placebo, and there were no adverse events leading to death. And personally, what I think this means for our patients and for us is that once this drug gets approved for this indication, we ought to be using it.
Yeah.
Despite we don't yet know what its overall survival impact might be and whether it's curative. You and I had a mentor 40 years ago, Dr. John Glick, who taught me very poignantly that disease-free survival is an endpoint in its own right. Patients generally have better quality of life before relapse than afterwards. So DFS should not be de-emphasized here.
Couldn't agree more. Sounds very practice-changing, for sure. Wow.
All stages of non-small cell lung cancer, we've got to be testing for a sensitizing EGFR mutation because there's now a therapeutic option that could benefit.
And that was really hit throughout the meeting. We've got to find, because we'll probably hit 100% one of these days, but now it's about a third. When I remember a few years ago, it was like 5%. So we need to look.
Absolutely.
So let me then go to next abstract on my hit parade of 5, number 2, abstract number 1000, easy to remember. Keynote 355 study, titled A Randomized Double-Blind Phase 3 Study of Chemotherapy with or without pembrolizumab for previously untreated locally recurrent, inoperable, or metastatic triple-negative breast cancer. So all comers of triple-negative breast cancer. Dr. Cortez presented in its international trial. So I've been fascinated by checkpoint inhibitors showing lots of promise, and I'll mention a new drug approval in a moment, in treating triple-negative breast cancer. And so this study extends that theme. It was a 2-to-1 randomization, and the chemotherapy was either nab-paclitaxel or paclitaxel or gemcitabine carboplatin, so 3 kinds of chemotherapy. And they randomized 2-to-1 to be with or without pembrolizumab. And the response rates, especially in those, as common theme, enriched in higher PD-L1 expression, something they call the CPS score, combined positive score, greater than or equal to 10 was especially impressive. And I just give some quick hazard ratios. If you're CPS 10 or more, you're a median PFS, progression-free survival, 9.7 versus 5.6 months. These are triple-negative breast cancers. CPS 1 or more, 7.6 versus 5.6. So a very positive trial, very statistically significant. And here's something now in the triple-negative breast cancer space. And I wanted to mention a recent drug approval, trade name Trodelvy, which is sacituzumab govitecan. I remember seeing this at ASCO a couple years ago when they presented. This is a drug-antibody conjugate. The triple-negative breast cancers are highly enriched in some marker called TROP2, TROP2. And so the antibody part of this drug-antibody conjugate goes for the TROP2, and it comes loaded with a topo-1 isomerase inhibitor, SN38, also known as govitecan. So a neat delivery system. I've just started using it in a couple of my triple-negative metastatic breast cancer patients. So here's abstract 1000, showing anything from early to metastatic, and the combination with a checkpoint inhibitor works better than without in the chemo regimen. And then we, of course, had this drug-antibody conjugate. Really interesting developments in a very difficult cancer.
It's kind of nice in this study, too, that as I remember, the chemotherapy partners that could be partnered with the pembrolizumab were a pretty broad range, fairly common regimens.
Indeed, yeah, the nab-paclitaxel, which I love, and then the paclitaxel or the gemcitabine carbo, yeah. All right, over to you.
I wanted to bring up another one of the plenary session presentations. The plenary session was just chock full of good practice-changing stuff this year. This was LBA-1, the Javelin Bladder 100 trial, and this was a study of maintenance of avelumab, another checkpoint inhibitor, versus best supportive care after platinum-based first-line chemotherapy in advanced urothelial cancer. And what they did in this trial was they looked at locally advanced or metastatic urothelial cancer who did not have disease progression after 4 to 6 cycles of a gemcitabine platinum combination, and they randomized them to either receive avelumab, a checkpoint inhibitor, every 2 weeks, or best supportive care. They stratified patients by a variety of factors that were very reasonable, and they also looked at tumors that expressed or did not express PD-L1. And what they found was that among the almost 700 randomized patients who were followed for a year and a half, avelumab significantly prolonged overall survival with a hazard ratio of 0.69. 70% of the avelumab patients were alive at 18 months, compared to 45% of the patients with best supportive care. Avelumab, as you might guess, worked particularly well in the PD-L1 expressing tumors, as chemotherapy did. In that group, the median overall survival for avelumab was not reached in comparison with 17.1 months for the PD-L1 expressing tumors that were treated with best supportive care alone. Toxicity, again, was an issue. There were about 12% of avelumab patients who eventually stopped treatment because of a toxicity, and grade 3 to 5 toxicities were about 47%, so about half the people had grade 3 toxicities. And again, what I think this means is that avelumab maintenance is there, and we need to be thinking about it and using it after cisplatin-based induction therapy, because this drug meaningfully prolongs overall survival in patients with metastatic urothelial cancer. I think that the presenter made the point very clearly that everybody wants to use checkpoint inhibitors in the second-line setting, but only about 50% of people wind up getting them because they progress so rapidly they wind up where they can never.
So you use it while you can, as per this study.
Yeah, giving the drug up front makes a lot of sense.
Well, very interesting, and I'm actually thinking of a patient where that might work in my practice. So on to my next one, I guess number 3 in my choice, which I found really interesting again, abstract number 4006, entitled Short Course Radiotherapy followed by Chemotherapy before Total Mesorectal Excision, TME, in locally advanced rectal cancer, the randomized Rapido trial. Now, I had to look up what on earth does Rapido stand for, and it's a catchy reason. Rectal cancer and preoperative induction therapy followed by a dedicated operation, the Rapido trial. So there must be some interesting poets in the Netherlands and Sweden where this was done. Dr. Hospers presented and came up with that acronym. So this was for locally advanced rectal cancer, which I've lately seen a lot of in my practice and been always attracted by the preoperative approach as opposed to postoperative, where patients don't always have the ability to get it because they're recovering from surgery. So in this trial, before we get to the trial, TNT is a popular neoadjuvant therapy, total neoadjuvant therapy, and you get 5 cycles of a Capox or a Folfox, and then radiation with usually a sensitizer like capecitabine, and then your surgery. So in this study, they said, all right, let's extend that theme, and they claim greater response rates and better outcomes if you give a short course of radiotherapy. This title of 3-5, it's called 5x5, meaning 5 days of 5 gray first only, then subsequent Capox or Folfox 4, followed by that total mesorectal excision versus, in this trial, the standard capecitabine-based chemoradiotherapy regimen, followed by the TME, followed by postoperative Capox or Folfox, standard of care. Large trial, 920 patients randomized, and the complete path response rate was 28% in the experimental, the 5x5 initial arm, versus 14% at a median follow-up of 4.5 years. They showed a 3-year disease-related treatment failure, which included local or metastatic. So 3-year disease-free, 23 versus 30. So the experimental arm wins there by 7%. And so this study, I think, continues to show that getting everything in ahead of surgery, your chemotherapy or radiation, in this case radiation and chemotherapy, can have better outcomes. And it's probably because you get more in before the patients have surgery, and it's harder to get them through the toxicity post-op. So I thought this continuing the theme of preoperative therapy, a potentially practice-changing study.
I couldn't agree more. And you know, that PCR rate is really very impressive. And when
Isn't
a
it,
patient
though? Yeah.
gets the PCR, it means they may be able to preserve their rectum. So it really has huge implications for quality of life.
Indeed.
The next one I wanted to bring up is a topic that happens in our tumor boards about once every couple of months. This was late-breaking abstract number 2, and this study addressed whether you should treat an intact primary breast cancer in a patient who has metastatic disease already.
Oh, yes. I remember, yeah. Mm-hmm.
Yeah, I mean, this comes up literally monthly for us. And this was E2108, a randomized phase 3 trial of systemic therapy plus early local therapy versus systemic therapy alone in women with de novo stage 4 breast cancer. They looked at about 250 patients who were treated with optimal systemic therapy, whatever the doctor wanted, whatever was appropriate for that patient's tumor after a discussion with the patients and agreement about optimal systemic therapy. They received that for 4 to 8 months. And then if the systemic disease was well controlled and there was no progression of the primary tumor or regional nodes, they were randomized to either continue systemic therapy or to have systemic therapy and localized treatment, whatever was appropriate for their intact primary disease, whatever their institutional standards were. There were about 40% of patients who dropped out for reasons other than progressive disease, but the characteristics of the randomized patients and the patients who dropped out early were basically similar. And what they found was that in a median follow-up of 4.5 years, so really pretty long follow-up, there was absolutely no difference in overall survival. The 3-year overall survival was 68% with or without local therapy. There was similarly no difference in disease-free survival, but as you might expect, there were more local regional relapses in the group that didn't have local regional treatment, but they then received, about 20% of them received palliative local regional treatment at a later time. The thing that really interested me about this was that health-related quality of life at 18 months was actually worse in the patients who received the early local therapy, although it was no different at other time points. But clearly, health-related quality of life was not increased by getting early local therapy. And I think that what this study means is that we probably should not be recommending planned treatment for intact primary tumors in most women who have stage 4 breast cancer. You know, if there's local progression, there is no decrement in overall survival, nor in health-related quality of life if we give palliative therapy to the primary tumor at the time of the local progression. I do think that the discussion made a really good point that there are a couple of studies now, one particularly that I want to put in a plug for, the RT Charm trial, Alliance 221505, that is ongoing to address the issue of whether there's benefit to treatment of oligometastatic disease or treating local disease in patients with oligometastatic disease. And that may be a special subset who deserves some early local therapy.
Well, I couldn't agree with you more. This comes up on our tumor board, breast cancer, at least every other month. And so one more reason maybe not to consider local therapy in the metastatic setting for that reason. So that was an interesting one. And my next one, number 4 of 5, is Abstract 8005, the Keynote 204 study, titled Randomized Open-Label Phase 3 Trial of Pembrolizumab versus Brentuximab vedotin in relapsed or refractory classical Hodgkin's lymphoma. Dr. Coriavilla, presenter, international trial. And in this study of some 300 patients, they randomized either pembrolizumab or brentuximab vedotin, and the results clearly favored the brentuximab arm, where the PFS, progression-free survival, hazard ratio 0.65, very significant, and that was a PFS of 13.2 versus 8.3 months. So I would just, and you could have had a stem cell or not before, so there were those patients who'd already had stem cell, or you could have had initial refractory disease. The results still favored the checkpoint inhibitor. And so I remember so well when brentuximab vedotin, a drug antibody conjugate, CD30 antibody loaded with a toxin, came out. Wow, this is great. And for our Hodgkin's patients to relapse, this is better. So another abstract when things coming along so fast for us to consider in this kind of Hodgkin's population who relapse or refractory. All right.
The last one that I wanted to bring up was LBA4, another plenary session presentation. This is the Keynote 177 study, and in keeping with the pembrolizumab theme, this is a study of pembro versus chemotherapy for MSI-high mismatch repair deficient metastatic colorectal cancer. And as you know, Dave, and as our listeners know, MSI-high colorectal cancer is about 15% of colorectal cancer and about 5% of patients who present with metastatic disease. And those patients don't respond particularly well or for particularly long to standard chemotherapy. But in the second-line setting, immune checkpoint inhibitors work really well with disease control rates that are as high as 90%. And they were interested to see whether pembro might work better than chemotherapy in the upfront position. So they randomized 300 patients with MSI-high mismatch repair deficient colorectal cancer to first-line pembro for up to 2 years, or to investigator choice chemotherapy with or without standard biologics, bevacizumab and cetuximab, and it was investigator's choice of what was the right treatment for that patient. They allowed patients to cross over to the alternative treatment for progressive disease or intolerance. And in a median follow-up of 2.5 years, pembro was clearly superior to chemotherapy for PFS with a hazard rate of 0.60. The 24-month PFS, for example, for pembrolizumab was 48.3% in comparison with 18.6% for chemotherapy plus biologics. So it was like 2.5 times better for disease-free survival at 2 years. Pembro had more responses, longer responses, and much less toxicity than chemotherapy plus biologics. The overall survival data is still not available and could be difficult to interpret because about 60% of the chemo patients eventually received an immune checkpoint inhibitor. But I think that what this means for us and for our patients is that for those who are not already doing it, we ought to be testing all patients with colorectal cancer for MSI status, because these results really do influence practice immediately. We should probably be using pembro as first-line treatment for these patients, even though we don't have the overall survival information just yet.
Yeah, I couldn't agree more. I saw this one presented and thought, wow, I want to be sure. Even though it's a small percent, if they have it, they'll likely respond. And, of course, this was second line, but maybe think about first line. Very, very impressive. And then that leads me to my fifth one, which you asked me. I thought, well, I'll look for a fifth one. You said, listen, Dave, do this one. And boy, you were right. Abstract 6002. Final OS, overall survival results from the SOLO-2 trial. Phase 3 trial assessing maintenance olaparib in patients with platinum-sensitive relapsed ovarian cancer who also had the BRCA mutation. And they were randomized 2-to-1 to receive olaparib 300 milligrams orally twice a day or placebo. Dr. Poveda presenting international trial. And it turned out that these patients had had at least 2 prior platinum-containing therapies. They had to be platinum-sensitive, I should underline again, and their follow-up was at least 5 years in the study. The overall survival improvement, not the survival, but the improvement, was 12.9 months better in the treatment arm, despite 38% of the placebo patients crossing over to this PARP inhibitor. The OS numbers were 51 months versus 38 months. So really spectacular. Time to subsequent therapy, 27 months versus 7 months. Median duration of therapy, they were on study at least 2 years. The adverse events from PARP inhibitor, typical, quite tolerable, and really spectacular results and practice changing. So I'm glad you told me I should review that presentation, which was well worth it.
You had originally brought it up to me. I think you just temporarily forgot it.
Oh, well, that happens a lot anymore, yes. Now, you had a honorable mention maybe, and I have one as well, so bring it on home.
Well, my honorable mention was abstract 1512. This was a study from the International Lung Cancer Consortium, and it asked the question among the almost 35,000 participants in the International Lung Cancer Consortium, what was the effect of smoking cessation at various time points on lung cancer patients' outcomes? And what they found was that among ex-smokers, the risk of overall death was reduced whenever a patient stopped smoking. For people who stopped smoking less than 2 years before their diagnosis of lung cancer, their overall survival was improved by 12%. And of course, it was improved by more the longer it was that they had stopped. 17% that they stopped 2 to 5 years, 20% that they stopped more than 5 years prior to their diagnosis of lung cancer. But somewhat counterintuitively, convincing patients to quit smoking at any point in their trajectory, even just prior to their diagnosis, seems to make a difference in survival.
Fascinating. You wonder if it's better, less COPD or better able to tolerate. Well, I have one. Go ahead.
I was going to say lung cancer-specific survival didn't change as dramatically, so it was some of the comorbidities that may have, terminated lives, as you mentioned, Dave.
Mm-hmm. Okay. So my last one, honorable mention, abstract 4005. What to do after you've taken a colorectal cancer metastasis out of the liver? Should you be giving, quote, adjuvant therapy after that or not? So this randomized phase 2-3 trial compared hepatectomy followed by FOLFOX6 or hepatectomy alone for liver metastasis. Dr. Kanemitsu presenting its Japanese trial. And these results have been mixed. I've never been that impressed that we should do it, and I think this, as you and I discussed, is probably the nail in the coffin. Some 300 patients randomized to receive either post-op therapy, FOLFOX6, or not. And they found no difference in overall survival. With a median follow-up of nearly 5 years, the disease-free was 52% for the adjuvant post-op therapy versus 41%, which was significant. But the 3-year overall survival, 86 versus 92% with surgery, not significant. 5-year overall survival, 69% with the combination of chemo versus 83% for surgery alone. So a mixed bag, but the take home to me and to the audience and the discussion was this is probably not a necessary strategy and certainly not standard of care.
Very good. Comes up all the time.
Yeah. So I think that's it. I hope our audience has enjoyed our run through 5.1 presentations of what was hot at ASCO, and really an enjoyable meeting given the circumstances and what they had to do. And I want to remind everyone you've been listening to our podcast, Blood and Cancer, which airs every Thursday morning on iTunes or wherever you receive your podcast from. And also, you can find us and archived issues on the journal webpage at mdh.com/hematology-oncology. And I've been speaking with my long-term friend and colleague, Dr. Alan Lyss, medical oncologist, associate professor of medicine at Washington University in St. Louis. And Alan, I really enjoyed, of course, working with you again. And this is our second annual, so many years to go. And maybe we'll actually see each other in ASCO next year.
Love it. Thanks very much for asking, Dave. I'm honored.
You're very welcome. Thanks for doing it. Thanks, everybody, for listening.
And that's a wrap on episode 74 of Blood and Cancer. I am the voice of MDH Podcasts, Nick Andrews. Blood and Cancer is produced and hosted by the editor-in-chief of MD-Edge Hematology Oncology, Dr. David Henry. Blood and Cancer is produced by MD-Edge editor Jennifer Smith. All MD-Edge podcasts are produced by the editor-in-chief of MD-Edge and the editor-in-chief of Medscape, Dr. Ivan Oransky, as well as MD-Edge executive editors Kathy Skarbek and Mary Ellen Schneider. I'm your audio editor, audio engineer, and the voice of MD-Edge Podcasts, Nick Andrews. You're listening to Blood and Cancer.